Good evening, everybody. Salam alaikum. And it's a pleasure, even if I cannot see you, but hope you see me. So tonight we'll talk about how the probiotics can shape the immunity of the baby. So I'm sorry if I can have some problem with technical, but I hope everything will be fine. So lecture outline will be that we'll talk about microbiota and intestinal function development, about microbiota, gut, and general immunity. Gut stands for gut-associated lymphoid tissue, and the effect of the probiotic on immunity. So as you can see in this cartoon, you can see how the intestine has a lot of function on and crosstalk with the microbiota. So due to the different tract of the intestine, we see that into the ileum, the microbiota have the main rule to talk about the, have a crosstalk with the gut. And we have also a different number of bacteria. While in the colon, not only bacteria have a crosstalk with the immunity, but also have a role in changing the bioreactor or metabolomic activity. And this, it's also important to know how the microbiota distribute into the different tract of the intestine. As you can see in this scheme, we have a high number of bacteria into the oral cavity. Then the number decrease in the esophagus and the stomachs, and then increase again in the small intestine and reach the highest number into the colon. Not only is changing on the number, but also we have a changing in the distribution of the phyla and in the kind of family we have inside here. And why is this? There is always a reason in nature, because into the colon, where we found the highest number of bacteria, we do also find the highest number of lymphocytes. Actually, the colon in the intestine, generally speaking, are located the highest number, the major number of lymphocytes that all the human body, more than in the spleen, more than in the lymph nodes. And they are organized as the Peyer's patches and or isolated lymph node follicles. And these are strategically situated in relation to the greatest concentration of the microbiota. But this is what's happening in the colon. But exactly what is happening between these two organs, let's say organ, because the microbiota is also an organ. So bacteria have a crosstalk with the lymphocytes, I told you. But the lymphocytes are not isolated themselves. They have a strong net of vessel that goes from the villi to the mesenteric lymph node and goes then through a net to the capillary lymphatic system. So we were here and saying that this connection, this strong connection between the lymphatic vessel, the lymphocyte of the intestine, the lymphatic vessel, and the blood vessel, make this effect of all this biochemical reactor that happen between the intestine and the lymphatic cells have an effect all over the body. But the intestine is not only a immune system, immune organ, but it also takes a lot of other systems. In fact, the biochemical complexity of the gut is the most complex of all the human body. So we do have the immune cells here that are in strict contact also with neuronal of enteric neurons, and these are also have a strong effect on all this immunity. So not only these are important, but also in critical role have the epithelial barrier or the intestinal permeability. These are the proteins that are supporting all the epithelial intestinal barrier and are extremely affected by the bacteria. So this is extremely important to know this complexity, because the microbiota into the intestine can affect more than one function, and all is reflected to the reaction of the lymphocytes. But go back to the immune system. What we can see is that the newborn is generally the newborn born immune suppressed. What this means? This means that the newborn has got all the anatomical cells of the immunity, but they need to be educated. And who is do this education? Basically the microorganism, because they can change the biochemical reaction. They can change the secretion of the dendritic cells of the lymphoid follicle into the intestine, but of course with a strong effect to the general system. But in this biochemical reaction, not only the adaptive and immune system crosstalk, but also this is the moment where the education of oral tolerance happen. And this is not only due to the bacteria, but also to their metabolites. So all the process of allergy and autoimmunity start in this very moment, because if the regulation of the inflammation of the intestine goes in one or the other direction, so we change all the mechanism of production of cytokine, creating a status of inflammation. But exactly what is the status of inflammation of the intestine? Generally, the intestine has got a steady state of inflammation. That means that we have production of pro-inflammatory cytokine, of anti-inflammatory cytokine. But if there is a dysregulation of microbes, if a dysbiosis happens, then there is an effect on these lymphocytes, on these dendritic cells of the intestine, then can go to a dysregulation and create a status of unbalanced inflammation. This status of unbalanced inflammation reacts and have an effect again on the other organ of the body. But let's go to see how this process of maturation of the immune cells goes exactly together with the process of maturation and colonization of the intestine. So you can see here, look, when the baby is born or prenatal, they have a very low number of bacteria and a very low number of Peyer's patch of lymphocytes and chromaffin cells. Then postnatally, there is a colonization, and we have to keep this colonization in a form of eubiosis, good bacteria that can produce metabolites that have an effort to maturate the lymphocytes and to create a status of education of these T cells that can produce cytokine that can be beneficial and can teach to the general immune system how to react. If this is dysregulated, then it can happen, and then all the start of process of autoimmunity can beginning, because with the cells of the lymphocytes, of the dendritic cells, well, of all the cells of the immune system, start to produce interleukin pro-inflammatory, and this can have a detrimental effect on the brain, creating multiple sclerosis, on the joint, creating arthritis, pancreatitis, all the process of autoimmune disorder. But all this interaction between microbes and immune system is also mediated by the nutrition, with the process of epigenetics. Exactly. Let's go step by step to understand. This process of changing is starting also and since the pregnancy, because if the mother is in a good condition, have a good food, then the baby can start to colonize even into the uterus with a status of eubiosis. And then in the uterus and during the pregnancy are starting this process of epigenetics. And what exactly is this process of epigenetics? We have our DNA. So the DNA changing the methylation can produce different protein. So we can have a different production of protein, and we can regulate our health producing good protein or bad protein. And this is the basis of all the health endpoints like diabetes, obesity, and hypertension. And this is also called microbiota and programming. In the microbiota and the programming of our future health, of course, are important the maternal factor, the microbiological factor, the way of delivery, and the way and the food that the baby is taking, breastfeeding or formula feeding. And generally, this early program and this crosstalk between the microbes, the nutrition, and the epigenetic happen in the famous 1,000 days, pregnancy and the first 2 years of life. Because after the second years of life, the microbiome is settled, is stable, is like the one of the adults. So during this period, this crosstalk, this interaction can have a very strong effect on the health, on the status of the health, because we can change the microbes, we can change the education and the development of the immune system, and we can change our reaction to the foods or to other components that come into the lumen. And this process of nutrition, microbiome, and epigenetic, again, is the key role of our health in the future. But so basically what we do need to have is a status of eubiosis. What we need to have is a balanced microbiota. And what are the factors that influence the microbiota composition? There are a lot of factors. Again, the inflammation I show you, antibiotics, hygiene hypothesis, but extremely important in our life is nutrition, is the diet, because intestine is challenged over and over again by nutrition, 3 times a day for the adults, 5, 6, 7 times for newborns. So this intestine is challenging continuously by the nutrients. And we have now, nowadays, some nutritional supplement that can induce eubiosis. So we don't have only the food that can help us, but we have also the prebiotic, probiotic, and postbiotic. And exactly tonight we will focus on probiotic. So the definition of probiotic is the last one that was stated by the International Society of Prebiotics and Probiotics is this. It's a live microorganism that, if administered in an adequate doses, have an healthy effect on the host. Moreover, to define a nutritional supplement as a probiotic, it has to got these activities. Have to be by human origin, this is extremely important, non-pathogenic, resistance, stability at different pH, have to adhere to the epithelial receptor to start all the biochemical process that I showed you before, have to have resistance into the intestine, production of antimicrobial substances, have immune modulation and metabolic effect. So what about the human Lactobacillus reuteri? The human Lactobacillus reuteri has its origin in breast milk. So it was identified by Professor Reuter, that renamed after him as Lactobacillus reuteri, and was isolated by Dr. Casas in the 1990 in a breast milk of a Peruvian woman. So the strain was cured from 2 antibiotic resistance plasmid in 2006 and then designated definitely as Reuteri DSM 17938. Lactobacillus reuteri has been a strain that has been very much studied in vivo and also in laboratory, and all the effect of this intestinal barrier in the gut has been shown that this strain increased the tight junction proteins between epithelial cells, increase mucus thickness, decrease epithelial leakage, and protect the mucosal barrier against the deleterious effect of all the agents that come into the intestine. So just create this intestine much more strong to the challenge of all the things that come in. So after all this study that has been done, of course, there are many, so I just took a summary. The preclinical studies show that Reuteri just makes the different layer of the mucosa and reduce the mucosal damage of inflammation. But this is the introduction of we start to have all the study in children. So this was one of the first study done in children affected by colic by Dr. Rode, where he showed that those baby affected by colic had a very high status of inflammation and had a very high level of calprotectin into the intestine. That means that the treatment with this strain can reduce the inflammation. And this was a very old study, but I like to quote this because was very intuitive. He just understand that there were a problem into the mucosa with inflammation. And 1 year ago, Dr. Savino just checked how this Lactobacillus reuteri had an effect on changing the inflammation of the intestine and the inflammation of this cytokine into the blood of baby affected by colic. So he took 2 groups of baby affected by colic. He randomized to receive Lactobacillus reuteri or placebo. And what he showed was that the baby who were supplemented with the Lactobacillus reuteri had a difference in this kind of cytokine into the blood. And exactly, you can see here that at the beginning of treatment, this expression of the FOXP3 and with the PCR had a difference before and after the treatment, so they just increase while they decrease in the baby with placebo. So what this exactly means? Means that these strains have a role in changing the expression of the gene of inflammation. So we should treat this inflammation of the intestine to have also an effect on the immune system. But what this is on the inflammation of the intestine, but is there any effect on the infection in general? So infection, all of you knows that is a leading cause of morbidity and mortality in children. So diarrhea and respiratory tract infection are the major cause of illness and death among young children worldwide. So of course, mortality is higher in the developed country, but also in any country, it's a very high incidence of infectious disease is common and just create a lot of problem in the society. But what is up on the intestine about this infection? So every child needs to have an immune system that is working properly to fight this infection. And this, I showed you before, is extremely up on the balance of the inflammation and the maturation of gut-associated immune system. And this gut-associated immune system is up basically on the microbes. So what is the role of a specific probiotic in changing, in modulate, and in protect the children during the infection? So there have been 3 double-blind randomized control studies with this strain, Lactobacillus reuteri DSM 17938, that have been shown that there is an effect in reduction in diarrhea, respiratory tract infection, less use of antibiotics, and reduced absence from daycare, and of course, a lot of cost saving for both family and community. So these 3 randomized double-blind control studies were done since 15 years. So the first was done in 2005 by Professor Weisman, and he checked the number of diarrhea, antibiotic use, and fever, and absence from daycare, and they were all less in the baby that were supplemented with placebo. Then in Indonesia, Dr. Agustina checked those babies only with diarrhea and antibiotic use, and shows again that those babies that were supplemented with this strain of probiotics had a reduced number of these 2 elements. And then Dr. Gutierrez in Mexico, he just took all the baby in the daycare center, so 336. He randomized those baby to receive reuteri or placebo, and he checked that all the baby who received the strain of Lactobacillus reuteri had a less number of diarrhea, less antibiotic, less day of fever, less day of absence of, from daycare, and also less respiratory tract infection. So definitely a dramatic changing in incidence of infection. And just I want to show you this paper. This was for prevention, and this was published 2 days ago. It's the new position paper by Estgan group of probiotic and prebiotic on acute gastroenteritis. And this, please note, that is the treatment. Even though with no doubt the acute gastroenteritis need to be treated with rehydration, the 3 strains of probiotic that have been identified again with like the previous, but they have been confirmed to be the most effective in reducing the time of acute gastroenteritis are the Saccharomyces boulardii, the LGG, and here the same strain of reuteri, DSM 17938. So the last slide I want to show you about this strain is its effect on allergy, because I show you at the beginning that it's not a matter of educated for defense against bacteria, but also the modulation for all the challenging, for the challenges that came, nutrients and other effects that can provoke allergy. So this was published 1 month ago. And in this study, the author assessed the effect of pre- and postnatal Lactobacillus reuteri supplementation on the DNA methylation. I'll show you all the effect of DNA methylation in the epigenetic processes in relation to immune maturation and allergy development. So they took the mother, so they supplemented the mother since the 36 gestation weeks of gestation and until birth, and then the child was supplemented from birth to the first year of life. Then they took the blood sample until the 24 months of age, the famous first 1,000 days. And what they show? They just show a changing dramatically in the expression of methylation of this gene, the gene that produces this IFNGA, the FOX3P, the interleukin 13, and the interleukin 17. So a changing of the expression of the genes. So what the authors say, they say that they demonstrate that this perinatal, so even during the pregnancy, supplementation of this strain affect the global DNA methylation pattern in the CD4 cells, in the supplemented infant. And of course, this is most pronounced at birth. The majority of the genes in this molecule were hypomethylated, suggesting that the probiotic intervention may lead to the transcriptional activity of these genes and then activate pathways concerning chemiotaxis, cell receptor, and signaling. Just to make a long story short, if we supplemented the mother since birth with this strain of probiotic, we can modulate the production of this gene, the production of some cytokine that can change our reaction to allergy. So this is almost a summary. Now just jump to the bifidobacteria and the effect of bifidobacteria. The bifidobacteria are extremely important for the infant, newborn and infant, because they are the major production of short chain fatty acid that we need to restore the epithelial cells. And also they are the major production of tryptophan. The tryptophan is the precursor of serotonin. So all the gut-brain communication. So inflammation, gut-brain communication, cell reparation. It's up on the bifidobacteria. And again, we do need to have basic study, and there have been a lot of study. This is quite an old one where it has been shown that this bifidobacteria, B. lactis BB12, induce a toll-like receptor 2 signaling to again trigger the gene expression. Again, it comes the expression of the gene of this interleukin. So effect on the in vivo study and what is done in children. So this infant premature baby supplemented with Bifidobacterium lactis with this randomized double-blind control trial show that it was a effect on the intestinal permeability in preterm. The preterm baby have a deficient intestinal permeability. But if we supplement it with this Bifidobacterium lactis, the permeability just has been restored quickly. There are a lot of studies. I want to show you this, where the Bifidobacterium lactis has been shown to change also the presence generally of all the phyla of Bifidobacteria, because Bifidobacteria are a lot of phyla, can be a lot of strain. If we supplemented the baby with the Bifidobacterium lactis, we have in these healthy full-term infants a high number of Bifidobacteria counts into the feces, similar to the one who have the breastfeeding baby. So resemble the effect, the Bifidobacterium effect, the bifidogenic effect of the breast milk. Another double-blind randomized control trial just show not only a higher count of Bifidobacteria in those babies supplemented, but also a lower level of Clostridium that are detrimental also as the Enterobacteria in these preterm infants. And this also another study that has shown where again, look, the calprotectin come again. The hormones of inflammation of the intestine is reduced when the baby is supplemented with this strain of Bifidobacterium, and also there is an increase of serum of a level of IgA. So enhancing the immune system, reducing the inflammation, always with the supplementation of the strain. Another also these studies out, this was a study of the Bifidobacterium into the milk and how this kind of formula just reduced the prevalence of diarrhea and in the children that were at residential care setting. Also, this is a very nice study on the prevention of acute infection, but this is doing with a mix of Bifidobacterium lactis and rhamnosus. And so this supplementation reduced not only the gastrointestinal infection, but also the respiratory tract infection. So they just were followed the baby for 12 months. And this is a nice study that I like because it's not only recent, 1 year and a half ago was published, but was used, this Bifidobacterium lactis, they ameliorate the risk of food allergy in this cohort of Chinese children affected by allergy. So this is the level of IgE in these children before the therapy and after the therapy. Look the control, look the Bifidobacterium lactis, how decreased the allergy of those babies. And not only was this the effect, but also was also related to the percentage of the T cells. So alleviate allergic reaction with the specific IgA and also the molecular mechanism that are behind this allergy. So T cells, Treg, FOXP3. So a modulation and a strong effect on the reaction of the allergy in those babies affected, diagnosed already by allergy. So what we can conclude that the microbiota shaped immunity in the children, that there are multiple strains of probiotic and the effects are strictly strain dependent. That these two strains, Reuter DSM 1798 and BB12, modulate the impact of intestinal inflammation state and play an impressive role in preventing infection. So thank you very much for your attention.
Professor Flavia, yes, as usual, the very engaging talk from your side. Thank you so much. Probably we didn't want the presentation to end. I think we have some questions as well from the audience, and if anyone is interested to ask questions, please post it on the Q&A tab at the bottom of the page. So we have something related to the first one, probiotics and Crohn's disease. Is there a correlation? Probiotics
I'm here on this question and answer. It's what is the, are you reading this question and answer or are you reading the chat?
No, the question and answers.
I found in this question, what is the dose of Reuteri in different indication, right?
That's one of them.
Yeah, so the dose of Reuteri in different indication is always the same. It's 10 to 8 CFU, that means colony forming unit. So it's always the same doses, even if the indication are different, because the doses is strictly related to the strain. So every strain of probiotic has its own doses. So LGG versus Reuteri in allergy prevention, we have both, always in also in LGG and also in Reuteri. I have to say the LGG was the first strain study in allergy. So the study of Erika Isolauri is the date 1997. So it's almost history. So they are coming, they are both efficacy in allergy prevention. The dose recommendation for children, I told you already, 10 to 8. And then pre-10 formula in probiotics, can it replace the need of probiotics separately? Well, this is a good question. I don't know how it is in Saudi, but in Italy, preterm baby cannot take formula supplemented with probiotic. They can take probiotic alone. I'm talking about preterm baby, and they cannot take the formula so far. So I strongly suggest, I mean, I don't know how is the legislation in Saudi, I don't know. So what is the rule of probiotic in preterm baby? Does your center use them routinely? Yes. In Italy, we have almost all the center use routinely for the prevention of necrotizing enterocolitis. So far, we do not have a policy. We don't have a national policy, but every NICU choose its own. Sometimes use Bifido, sometimes use Reuteri, sometimes use LGG. How long should we give probiotic for? It depends on for what you want. For instance, if you want to cure colic, then you have to use it at least 1 month. I suggest to use it until the complementary feeding is finished. If you want to cure acute gastroenteritis, then you have it 7 days. If you want to use for antibiotic-associated diarrhea, then you need it to have for all the time you give antibiotics. Role in the treatment of neck, this is another meeting. So there is a position paper of ESPGHAN has been shown that there is an effect and efficacy of probiotics, but every probiotics need to ensure safety, and all not the probiotics are the same. I have to be sincere, Lactobacillus reuteri so far for necrotizing enterocolitis is not the first choice. So do you recommend the use of isolated probiotic in treatment of infant diarrhea? No, I say that the infant acute diarrhea needs to be treated with rehydration first. Then you can have your probiotics between the 3 I show you, but as an adding therapy, just to reduce the time of diarrhea, because the treatment, again, I will never be tired to say these things, treatment of acute diarrhea is rehydration. So can we consider that the pathogenesis of infantile colitis inflammation? Because the positive effect, yes, one of the pathogenesis of the infantile colic is inflammation of the intestine. We don't know which is causing the inflammation, but for sure has been shown so many times that the children affected by colic have the intestine inflamed. Difference between prebiotics and probiotics. Probiotics is a live microorganism, Prebiotics are some biochemical structure that are not live. So they are like the fiber. There's a nutritional supplement without DNA, RNA inside. Probiotics are live bacteria or other fungi or viruses. Okay. I think I answered all the questions.
I think there were a couple of ones when you were disconnected, the relation between,
Yes, please.
would you consider Crohn's disease? Would you consider probiotics for them?
For Crohn's disease and generally for all the inflammatory bowel disease, the probiotics are not recommended as a therapy because they need a more complex therapy. There are some cases only in some very light or mild ulcerative colitis. We can use probiotic as enema, or also in the pouchitis, the WSL3. So here, any guideline or website for extra reading, if you go to the JPGN, you can find, I think you can download for free the guidelines of acute gastroenteritis, of necrotizing enterocolitis on the website of JPGN.
There's another one, is the role, what's the role of probiotics in preterm babies? Does your center use them routinely? If so, which one?
My center is using routinely Bifidobacterium for preterm baby.
And there's one about
in the prevention of necrotizing enterocolitis. If we have some late preterm with the enteral feeding intolerance, we use Reuteri because Lactobacillus reuteri is much more effective on feeding intolerance in preterm. So it depends what you want, what is your goal, what you want to achieve.
Okay, so there's one more on fecal transplantation and the effect on the immune system.
Fecal transplantation is used only on Clostridium difficile relapsing infection. So no different, is not for modulate immune system, but to change totally the microflora.
Perfect. Yeah. Okay. So let them work on it, and I think we can now start with the other quick clinical experience part related to your COVID management, or how do you see the respiratory infections going these days?
Yeah.
So we'll leave the floor again to you.
Okay. So let's go back again to this COVID infection. And first of all, as all of you know, the COVID infection in children, it's not severe and have a very low incidence compared to the one in adults. Okay, so how can we, first of all, diagnosis? I have to be sincere, there is only one article that has been published in children, and this done by the Chinese experience. It's published in pediatrics. It's open, you can go, pediatrics is giving this for free. And it's done on around 2,200 children. And first of all, they define the diagnosis. So they say that the clinical criteria to diagnose a coronavirus infection in children is fever, fatigue, dry cough, and some pediatric patient may X-ray. You find a multiple small patchy shadow and interstitial changes, bilateral and also infiltrating shadow. But first of all, we do need for the final diagnosis, we do need the CT scan. And then the white blood cells counts are normal. Just tell me, can you hear me?
Yes, hello? We can hear you very well.
Yeah. Okay, perfect. So this is the diagnosis. Then this article show in this very large cohort, around more than 2,000, exactly 143 children, they show a difference in ages. So they say, if the baby has got a coronavirus when he's less than 1 year of age, he's got a very high percentage to have a critical situation. And so is when he's adolescent, after 10 years. But there is a area, this, let's say, blue zone, I should say, where the children seems to be safe. From 3 years until 10 years, they have almost 0 cases of acute respiratory tract disease. And what is the explanation? Nobody knows, only speculation. the children are less sensitive to coronavirus infection. Why? Maybe because the maturity and function of ACE2 in children is lower than in adults. And moreover, the children additionally often experience respiratory tract infection and may have higher levels of antibody against virus than adults. Maybe, who knows? These are hypotheses, need to be confirmed by other studies. How can we make the diagnosis in children of coronavirus? The diagnosis is with PCR, swab and PCR. No other possibility so far for the diagnosis. How can we treat the children of coronavirus? Of course, we do need supportive treatment, including sufficient fluid and calorie intake, and we need oxygen supplementation if there is an acute respiratory syndrome. But we want to do treatment in order to prevent this acute respiratory treatment. So what is the treatment when the baby is positive? The only possibility to block the advancing of the infection with acute respiratory tract is the nebulized interferon alpha 2b or oral lopinavir or ritonavir with corticosteroid if comes to complication. We can use also intravenous immunoglobulin for severe cases. Another frequent question is, there is any vertical transmission from the mother to the fetus, to the newborn? In Italy, we create a national register. We have now around 60 women who positive to coronavirus who delivered the baby, and none of the baby were positive to coronavirus. So we didn't find any vertical transmission. Another question is the breastfeeding transmitting the virus? And the answer is no. Breastfeeding is not transmitting the virus. The baby who are born from a coronavirus mother positive can be breastfeeded, but it's better to do it with express breastfeeding, because the connection, the close contact from the mother to the baby, this is not indicated. So at least until the mother is negative to the swab. So this is our Italian experience. Very low incidence of baby, no vertical transmission, no severe case of acute respiratory distress syndrome. Okay, we can go with the question, if any.
Perfect. So if anyone has any additional questions, please post it at the Q&A section. And I think the question that's popping up here is, do you consider chloroquine as a thiopurine for those infants or children?
No. So guidelines and Italy, no immunosuppressive drug, only nebulized anti-interferon beta.
Okay, and is there any special precautions that you take with the COVID positive mother and the negative infant?
Sorry, say once again.
Special precautions that you take with the mothers with the COVID who
No.
delivered?
The only things it's to not put mother and newborn to strict contact until the mother is negative to the swab.
Okay, one more thing. Would you consider vitamin D supplementation?
Yes, the vitamin D has been shown to be protective in children also and in adults.
And would you keep the same vaccination scheme? And there's another one. Do you see that BCG adds value or reduces
no, BCG is not adding
COVID?
any value. No, vaccination BCG not adding any value, and all the vaccine schedule needs to be kept with the precaution, of course.
Okay, so you wouldn't delay it?
No.
Okay.
because it seems that this challenging of immune system with vaccination helps the baby, helps the children. This could be one of the reasons why the children looks to be less sensitive to coronavirus infection.
Perfect. So I guess we're mostly on time.
Yeah.
Some more questions coming. What investigations would you request?
Yeah, I'm just.
Yeah.
What about treatment of newborn infected? Is the same as infants? Yes, it's the same as infants. If any, again, we don't have any. What's investigation you request in COVID? Swab, and I told you, swab, CT scan, and any death in children, and what the reason behind. In Italy, we had no death in children, any. We had more than 30,000 deaths for coronavirus in 3 months, but no children.
Lucky we are, thanks God.
Yeah, thanks God, at least.
Yeah.
Okay.
There's a question about zinc. There's a question about vitamin B.
No, vitamin B. Vitamin B protect from what? Can you repeat? No, vitamin D. D like door. Vitamin D. What about pulmonary embolism? Is not well. In Italy, we do not have. Has been reported as more than pulmonary embolism is a thrombotic problem, generalized thrombotic problem in adults, but it's not been reported again in Italy. This pediatric, I can talk about Italy, not about generally. Yeah.
Okay.
Is another. Severity of COVID according child age, I say this. This is reported by this study of Chinese.
Vitamin C, does it have an impact?
No, the severity of COVID, in fact. What about vitamin C? There's no evidence, nothing, no report about this.
You see a derangement in the white blood cell count, leukopenia?
B cells mostly normal, not leukopenia, no, almost normally, no. What about breastfeeding of COVID mother? I answer to this, that can breastfeed but expressed. They should use the pump, breast milk pump, and give to the baby. As far the mother kept positive swab. Where recommendation lactating mother can give breast milk as long as she's using PPE? Well, I say not according to Dr. Flavia. I say what we are doing in Italy.
Yeah.
Not according to me. These are there's some how do you say, some the Italian Society of Neonatology make this statement. Yes, exactly. I can send you, but they are in Italian. It's not, I mean, this is because I explain why. Because if you just can imagine that not all the mother, well, in Italy, 100% of the baby and 100% of the baby of COVID plus mother are born in a COVID hospital. We are creating COVID hospital, gynecology department, birth COVID department. Can you imagine how many government can afford this? So we have all the procedures, safety with this. If this is not, then you can use the PPE. But I'm sharing with you the Italian experience, not the World Health Organization experience.
There's a case report in the UK with a newborn.
Of newborn, the one, yeah. There is also there are also deaths in Belgium, in England. In Belgium, there was a death of 11 years boy or girl, I was, by coronavirus. Yes, yes, there are. Again, I don't know about this. I'm talking about, yeah, so far in Italy, we didn't report transmission. You know what? The problem is that this infection is very new. We don't know. We don't know even the whole epidemiology. In Italy, since in 1 week, we'll start a national study to check all the population, just to understand the incidence and the epidemiology. We are testing the blood to see if who is got the antibody. So just to check at this general immunity, in which stage it is. But so far, there cannot say a very strong statement on this virus. So we have positive asymptomatic children in cases. We need to start Zithromax since results were negative for children specifically. No, if you have a negative results of the swab and you have, if you have asymptomatic with positive swab, why do you have to start therapy? You have to isolate the child in quarantine and follow him. You don't need to start anything if there are no symptoms. Vitamin D protect newborn, positive mother dose and duration. The dose is the standard 400 unity, and duration you can give 4 months. What's the most prominent clinical presentation in pediatric? For how long persist? The most prominent presentation, I told you, cough, 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 because some children cannot have fever. And how long persist is not a state. I mean, it's very, it's changing. It's very individual. Maybe another.
Yeah, more questions coming.
What's the positive blast investigation most you notice in COVID? No, I'm not working in a COVID hospital. I'm not working in a COVID hospital. So discharge criteria of COVID positive neonate. Well, mother positive. When the mother is negative to the swab, they dismissed the swab. Again, I told you, no vertical transmission reported in Italy. Vertical, from mother to newborn.
Antibody rapid test, a screening test for massive screening in case PCR is not available. Do you
recommend antibodies rapid test as screening? Is not sure. It's not. This is not the diagnosis. This antibodies rapid test is in the second phases when you want to know the epidemiology. Who is positive? Who is developing the immunity? Even if it was not positive. But for diagnosis, only PCR. Because with the test, you don't know if there is a past infection, you don't know the timing of the infection.
Okay. There's one question as well, back to the probiotics. Would you give probiotics to infants after an antibiotic course?
No, there is another. Do you treating patient using the plasma or recovered? Yes. Now we are using in Italy this. Do you treating the patient with the plasma of recovery? Yes. Yes, we are using. Yes. Immunoglobulin coming from plasma. Yes. What other about probiotics? I don't find.
After antibiotic use in infants, would you recommend a certain probiotic after antibiotic usage?
For the antibiotic, there are guidelines also for this antibiotics associated diarrhea, and this LGG, Reuteri, Saccharomyces boulardii, almost the same tree of acute gastroenteritis.
All right, so I think we had a pretty engaging session today, and as usual, your presentations and your sessions, probably we don't want it to end, but thank you for your time, thank you for your effort, Professor Flavia. You made the day for sure, and I thank also the audience for their interaction, their questions, their comments, and their responses as well, and thank them as well for being with us today. Probably it's a little bit late now, and thanks a lot, and we'll keep in touch with more sessions to come, and we'll be in touch with Professor Flavia as well if possible.
Okay, bye-bye. Bye-bye.
Thank you so much, and have a great night.
Yeah, good night. Bye-bye.
Thank you, everyone.
Thank you to you. Thank you to you all. Thank you.
Thanks, and Ramadan Kareem to everyone. Have a great night. Thank you for being with us.